And before we begin, it is my pleasure to introduce today's lecturers, Dr. Jennifer Furin and Dr. James Seddon. Jennifer Furin is an infectious disease physician and anthropologist who has dedicated her career to providing health care for the sick and poor around the world. Dr. Furin has worked with patients who have MDR-TB since 1995 and has treated hundreds of children with the disease. She currently leads the Capacity Building Task Force at the Sentinel Project on Pediatric Drug-Resistant Tuberculosis and serves as a regular consultant and strong advocate for children and families affected by this disease. Dr. James Seddon is an academic clinical lecturer in pediatric infectious diseases at Imperial College London. He divides his time between clinical work, research, and teaching. The clinical work takes place in St. Mary's Hospital as well as Great Ormond Street Hospital and includes the care of children with complex infectious diseases as well as those with immune deficiencies. And his major area of research is that of children with tuberculosis and specifically its drug-resistant forms. So I will now turn you over to Dr. Jennifer Furin. Thank you.
Great. Thank you so much, Evgenia, and thank you, everyone, for joining us for the presentation this morning, or this afternoon, as it would be for some of you. I'm basically going to present with Dr. Seddon a case of a 3-year-old child who presented with fever, lethargy, and difficulty walking. It's actually one of the first children I ever took care of with drug-resistant TB, and we'll do the case presentation. There'll be the opportunity to answer some questions and to see what your guys' thoughts are on the case, and then I'll hand it over to Dr. Seddon for a more in-depth discussion. Just to mention the Sentinel Project on drug-resistant TB, for those of you who don't know, we're a virtual network that was created in 2011, and our goal is to share interest information and advocacy and research for children who are affected by drug-resistant forms of TB around the world. So if there are any questions about joining the network, please let us know and we can answer those. I have to warn you all, I tend to talk fast, so if I'm talking too fast, please tell me to slow down in the question for experts section. So the objectives of the workshop today will be to illustrate a pediatric case of MDR-TB, to demonstrate when to suspect MDR-TB in a child and when to start treatment, to understand how to construct an MDR-TB treatment regimen in a child, to consider dosing calculations of the second-line TB drugs, and to review recent and future developments in the treatment of MDR-TB in children. As you'll note, we're not going to be talking about adverse events, prophylaxis, or adherence strategies today. Rather, there will be another webinar in June. We'll announce the dates, led by Dr. Tony Garcia-Prats and Professor Simon Scaff from Stellenbosch University and the Tutu Center. So they'll be talking about those issues. So moving into the case, when I met this young boy, he is a 3-year-old boy who's been in the hospital for 4 weeks at the time of consultation. He was brought to the health center by his mother nearly 6 weeks ago when she noted he was febrile, lethargic, and seemed to have little interest in playing. At the health center, he was given some antibiotics and told to come back in 1 week. The following week, his mother brought him back, and she reported to the health center that he was no better and that he seemed to want to be carried all the time. So at the health center, they were given some vitamins and once again sent home. 6 days later, his mother brought him back to the hospital. Brought him to the hospital. She didn't go to the clinic again, but took him to the hospital when she noticed he could no longer stand on his own, and she also found a lump on his back. At this time, she also noted that he was coughing and losing weight and was barely eating anything at all. So we have some questions or some things we'd like to think through as a group, and Evgenia will help by giving us some prompts here. But the first is, what is the most likely disease to consider in the differential diagnosis of this child? So if everyone could take a minute to punch in their responses, leukemia, tuberculosis, meningitis, or bacterial pneumonia. Great. So a majority of you picked the correct answer, which is TB. Although the other answers are possible, this is a child who's presenting with signs and symptoms of active TB, including lymph node swelling, some definite signs and symptoms of meningitis, and some cough. So So the next question is, if you were seeing this patient at the hospital or in the clinic, what additional information would you want to know? And again, I realize there'll be a lot of information we would want to know, but looking at the choices, which would you pick that you would most like to know? Great. And again, a majority of you picked the correct answer here, which is it would be important to get a contact history for TB contacts to know if the child has had BCG vaccination and to know what the child's HIV status is. So, and it seems like everybody understood that one. Continuing on in the case, when you examine the patient, he's found to have a temperature of 39 degrees. Even though he's 3, his weight is only 8.2 kilograms and his length is 67 centimeters. On exam, you find that he's pale and listless, he has lymphadenopathy, he's tachypnic, and he has crackles and wheezes in his lungs bilaterally. He has absent ankle reflexes, and he has no spontaneous leg movement. So the child is reported to be fully vaccinated. We do not know his HIV status, but the mother reports that there's an uncle who lives in the house with them who has just been diagnosed with TB. And then the child had a chest x-ray, and he was at a very good hospital, so he underwent an MRI of the spine. So let's take a look at the x-ray, which would be the next slide. Sorry, I'm in charge of that. So this is the chest x-ray of the child. And then just to get everyone's opinion, what is the most likely cause of this x-ray appearance? And I'll put the x-ray back up so you can take a look at it. So again, what do you think is the most likely? Good, and everybody got that correct too. Miliary TB. So this is the classic sort of millet seed presentation, and this is a child who is clearly sick with what we think is acute and disseminated TB, otherwise known as miliary TB. Reactivation TB would be less likely in a child of this age and would tend to present in the upper lobe or the apices of the child. And then this was an image of his spine, which was taken with an MRI machine, and the abnormalities are seen in the center. Oh, I have a little pointer somewhere here. So the abnormalities are seen here and here, both within the cord, but then also in the vertebral bodies. So then moving on in the case, the child was admitted to the hospital. He was actually started on first-line therapy with isoniazid, rifampin, pyrazinamide, and ethambutol. And at the hospital, they obtained gastric aspirates, and those were shown to have acid-fast bacilli, but cultures were not done on this specimen. And this was actually standard in the National TB program at the time that this child presented. And depending on the setting that you're working in, I think you may also find this as well, that culture facilities may not be available depending where you are in the country. So he was started on first-line therapy. He was started briefly on corticosteroids, but these were stopped after a week as his physician decided that he had Pott's disease and not TB meningitis. So moving on with the case history, the child's condition continued to deteriorate, and eventually he became bedbound. He couldn't get up, he couldn't move, and he lay almost motionless in a crib. He was now requiring oxygenation around the clock, and he was so malnourished he actually began to develop pressure sores all over his body, including over the bridge of the nose where the oxygen mask was placed. This is a really sick child. He's on anti-TB therapy, and he's clearly not getting better. So the first question I'd like the group to consider is, what do you think the most likely cause of his deterioration is? And Evgenia can show us the questions here. So what do you think is the most likely cause of his deterioration? And the majority of you picked drug resistance, which is a good answer considering you're attending a lecture series on drug resistance in children. So, and in fact, it is the correct answer. Immune reconstitution definitely could be a possibility here. And this is sometimes very tricky in managing children who have central nervous system tuberculosis. This is more common in patients with HIV. However, we sometimes see immune reconstitution in HIV-negative children. And as most of you know, this is the paradoxical reaction where people actually get worse with treatment before they get better. And then the next question is, what information do you think would be most helpful to try and get now that you've had this child who's admitted, who's not getting better, even on appropriate therapy? And again, we'd probably want to get a lot of this information, but the most important, and again, all of you answered this correctly, would be detailed information on his uncle who has TB. So we know the uncle's living in the home and we know he has TB, but we didn't hear much else about that. So upon further questioning, actually, the mother reported that the uncle who lived with them was started on treatment for a form of what she called strong TB. And it actually turned out on further questioning and review of the uncle's medical records with the team taking care of the uncle, he actually had MDR-TB, and he was resistant to isoniazid, rifampin, ethambutol, and streptomycin, and that the uncle was actually on a regimen of pyrazinamide, kanamycin, levofloxacin, ethionamide, and cycloserine. So for our little patient, little Mr. CC, once you have this information, what do you think would be the next most important thing to do? So would you want to obtain samples for DST, start empiric therapy, do both, obtain samples and start empiric therapy, or put him on steroids? Okay, and again, it looks like the majority of patients are picking the correct answer, which is get samples and start empiric treatment. Oftentimes people will get samples and wait for the samples before they start empiric therapy for children suspected of having MDR-TB, but as Dr. Seddon will point out later, with certain forms of DRTB and in certain children who are clinically ill, waiting for confirmation can be a deadly decision. So it's correct. We want to get samples, but we want to start him on therapy as quickly as possible. And then the next question is in the case discussion is, what drugs would you put in his treatment regimen? And I'll let Evgenia put some examples up there. People can take a little bit of time to think these through. Great. It looks like, again, we don't need a whole lot of time. People would recommend, and correctly so, putting him on a regimen that takes into account the drug susceptibility pattern of his household contact, which would be his uncle. And so that regimen would be pyrazinamide, kanamycin, levofloxacin, ethionamide, and cycloserine. Excellent. So I will at this point actually, after presenting the case, hand the discussion over to my colleague Dr. Seddon to give you a little more background and discussion on how to manage children like these. We'll come back to the case discussion in a little bit, but Dr. Seddon, take it away.
Thanks very much, Jen. And it's an absolute pleasure to be speaking, and great to see so many familiar names on the list of people who are attending. So I'm going to talk a little bit about the sort of theory behind what Jen has just been talking about. And I'm going to briefly touch on an algorithm which is contained within the Sentinel Project field guide, which you'll find if you go to the Sentinel Project website. You can download this field guide, and it's hopefully it was designed to be a user-friendly guide to how to manage children with drug-resistant TB. It looks quite big, this algorithm, and I'm going to break it down into a top half and then a bottom half. So starting off with the top half, so when should you consider a child might have drug-resistant TB? And the circumstances are either when they've been treated previously and they're presenting very quickly again with TB after finishing a treatment course. So that's bullet one. Then there's the situation where they've been in close contact with someone who you know has MDR-TB, and either that's a household or a school or a social contact. And then also, though, we must at the back of our mind think, have they had close contact with someone who has risk factors for drug-resistant TB? So someone who's died or failed TB treatment or is not adherent to therapy. So someone who maybe not confirmed with MDR-TB but has a lot of risk factors for it. And the final circumstance when you really should be, flags should be waving, is when you've got a kid who's on first-line therapy and you're pretty sure that they're adhering to their therapy very well and they're just not getting better from it. And in those situations, you really need to think, maybe as this child has been on, they've been on, the case that Jen's been talking about, this child's been on first-line therapy, we're pretty sure that they're taking it well because they're in hospital, we're pretty sure the doses are right, we're pretty sure the diagnosis is right because we've got AFBs there. So, and they're just failing therapy. So in that situation, you need to consider it. So if you don't have any of these risk factors, the safest thing to do is just to continue evaluation for drug-susceptible TB. But if you've got any of those risk factors, and in this case that has been described, you've actually got a couple. You need to move down the side of the algorithm where down over here that says yes, and start thinking about assessing for MDR-TB, which includes getting as many microbiological samples as possible, getting sputum if they're old enough, induced sputum or gastric aspirates if not, getting other samples such as lymph node aspiration biopsies if there's any lymph node that's possible, to really maximize your chances of getting a microbiological diagnosis. Okay, and then we move down to this bit in the algorithm, and you can either have a result from your diagnostic workup or not. If you do get a result and you confirm MDR-TB, you should treat according to that DST. So if you've got a DST in the child, treat accordingly, use drugs that are going to work against that DST. If you have drug susceptible TB confirmed, that's kind of a great result to get that back, because it saves the child a long and unpleasant treatment course, and you just give them normal TB treatment. But if you haven't got a diagnosis, or you don't really have any diagnostic workup available in the context you're in, you give them two options really. First option, which is over this side, is if they're okay, the child's absolutely kind of relatively stable with what you think is clinical TB, and you think you've got some time to play with, if they've just got early infiltrates or kind of early respiratory TB and they're kind of okay and stable, they're a bit older and you've got some time, you can wait perhaps and wait for the diagnosis, the results of your microbiology. However, if you're concerned at all about this child and there's a contact and you're concerned that they might be unwell, as in the situation with this case, really you need to start empiric therapy. And that's what we're going to, if one thing to take away from this session today is, if you're concerned about a child and they've got risk factors for MDR-TB, starting empiric therapy while waiting for results is the right way to go. So the next thing is, how do we decide? So you've made the decision you're going to treat them for drug-resistant TB. How do we construct our regimen? How do we think about the drugs? So if we start at the top, you've got drug-resistant TB, you're diagnosed, or at least you've made a decision to treat. Now the first line drugs, the group 1 drugs as the WHO call them, are the best drug. So if there's any chance these drugs will work, you should include them. And so pyrazinamide, unless you've got evidence that the bug is resistant to pyrazinamide, you should probably include it. Ethambutol is a bit more questionable because often the resistant test is not so good, and also, or not so reliable at least, and also in circumstances where organisms are resistant already to isoniazid and rifampicin, they're frequently resistant to ethambutol as well, and pyrazinamide, but ethambutol particularly. We put rifampicin here. Now this is maybe confusing because it's an MDR case, but there is a place for rifampicin if, for example, you're treating based on a failing regimen, or where you've got one drug-resistant source case and one drug-susceptible source case. It's fair to give 6 months of rifampicin just to cover in case this child has a drug-susceptible organism. You then move on to add a drug from group 2, one of the injectables. You add a drug from group 3, one of the fluoroquinolones, and then you keep adding drugs from group 4 until you've got 4 active drugs. So you add ethionamide or prothionamide, taururzidone, cyphosirine, or PAS. And if you still haven't got 4 drugs that you're pretty sure are effective at this point, you can move into the group 5 drugs, which have less clear efficacy or have higher toxicity, or we don't really know how to use them. So that's really an algorithm for thinking about how to construct your regimen. Now, some of you will work in situations where there's a lot of HIV, and some of you will work in situations where there's really not much HIV, but I think it is important to know how HIV plays into the management of drug-resistant TB, because there's obviously the potential for a large amount of drug-drug interactions, different toxicities, and things like immune reconstitution. So really there are 2 different ways that children with HIV and drug-resistant TB can present. So the first side, which is actually a bit simpler, is if the child is known to be HIV and already on antiretroviral therapy, and they're established and they're stable on their antiretroviral therapy. And if that is the case, you should just start the drug-resistant TB treatment immediately and just plow on with that. However, and more complicated, if at the time you make the diagnosis of drug-resistant TB or decide to start treating for drug-resistant TB, you make the diagnosis of HIV, or alternatively, we know they're HIV positive, but they're not yet started on antiretroviral therapy. It's a bit tricky. And the priority is to start TB treatment, but you want to start the antiretroviral therapy as soon as possible after that, because really sort of supplementing your immune system, getting your immune system back on track is going to help you with the treatment of TB probably as much as anything. So we usually suggest starting the TB treatment and then after a couple of weeks starting antiretroviral therapy. And there are lots of things that can happen. There's a high pill burden, there's a lot of overlapping toxicities, the drugs can interact with each other. So it is challenging starting with, you know, these two drugs in rapid succession, these two drug regimens in rapid succession, but it is important to get them going. The one thing you really need to worry about is iris, and this is where, as the immune system starts to reconstitute, it leads to a sort of overwhelming inflammatory response. Now, if at all possible, you want to try and keep going with the antiretroviral therapy, and it may be that you might be able to try some steroids, or you might be able to just manage them through it, nurse them through it until they get through the other side. But if they're really, really sick with their iris and it's sort of life-threatening, you might need to stop the antiretroviral therapy, wait till maybe they've had 4 weeks, 6 weeks of the drug-resistant TB and they're a bit more established on that. Maybe the mycobacterial load's a bit lower, a bit less antigen on board, and then when you start the antiretroviral therapy, hopefully you won't get such an immune response. In terms of some general rules, just because of the toxicity of D4T, we generally say avoid it. That's not always possible in all regimens and in all countries, because some places that's really what you've got. Also, if you can at all avoid it, the combination of ephedrins and cycloserine trazodone, both of them have neuropsychiatric side effects. So if at all possible, it's best to try and avoid that combination, especially in older children. Tenofovir we don't use very much in children, but it's coming in more and more for the older children and probably will come in more and more for younger children as time goes by. And that has obviously renal side effects, which can exacerbate problems with injectables, which also have renal side effects. Okay, I'm just seeing if there are any questions about that. I don't think so at the moment. I'm going to move on. If we can pick up questions at the end if we haven't addressed them as we're going through. So the next thing I'm going to talk about is the drugs and the usage of the drugs, how we prepare them and how we dose them. So this is a kind of table for oh, sorry, I've got a question. What is iris? Sorry, I'll go back because I think it's worth addressing that if people haven't picked that up. So iris is immune reconstitution inflammatory syndrome, and that is where when you start TB treatment and then you start antiretroviral therapy, you get the immune system waking up, as it were, and recognizing the antigen that the TB is releasing and getting an overwhelming immune response. Okay, so these are drug dosages that are now recommended, and these have modified a little bit over the last couple of years in light of emerging pharmacokinetic data in children. So what we're seeing is that we're using the first-line drugs right at the top end of the dosing range. And we do use isoniazid in the treatment of drug-resistant TB, particularly when you have an INHA mutation. So isoniazid resistance is either caused by an INHA mutation or a CAT-G mutation. And when there's an INHA mutation, isoniazid might still have some efficacy, especially if you give it at this high end of the dosing range, 15 to 20 milligrams per kilogram. For ezetimibe, we give high end of the dosing range anythambutol. Then we give the injectables. Now there's some emerging evidence that actually we probably should be using slightly lower doses of amikacin, and I think that will come out in publications in the next 6 months or so, that maybe we should be aiming for more like 15 milligrams per kilogram of that to achieve blood serum concentrations that you want. Fluoroquinolones, also these recommended dosages are being revised. Levofloxacine's been revised in the last real year in light of good PK evidence coming out of South Africa mainly, saying we're able to give this once a day at a higher dose. But moxifloxacin was still recommending 7.5 to 10 milligrams per kilogram. The ethionamide trazodone, higher end of the dosing range, up to 20 milligrams per kilogram and past 150 milligrams per kilogram. Linezolid, I don't think we really know what dose we should be giving is the honest truth. Probably giving it at the dose that you give for bacterial infections may be excessive, to be honest, and it may be you get good efficacy with a lower dose without having some of the side effects you see at the higher dose. So I think there's going to be more to be said about linezolid, and I'll talk about it a bit later. Augmentin has some potential efficacy, as does clarithromycin, and these are the drug dosages that are currently recommended. This is a chart that's been developed by a group within the Sentinel Project to think about trying to help people use dosages and to dose people. So what you do, and it should be fairly self-explanatory, I think people are quite used to these kind of charts for HIV, is you take the weight going down of the child, so you get, say, 10, if they're 10 kilograms, and you go across, and this tells you how much of that type of formulation you need to use. So if they're 10 kilograms and you want to use ofloxacin, you want to give a 200 milligram tablet and you give 1 tablet of it. So this is just to help, and it's nice and colourful and pretty, so it should make everything easier. That is available on the Sentinel website. And I just want to illustrate with this point how tricky it can be to dose, to use these medications in children, because we're stuck with adult formulations, and hopefully this will change in the coming years. And I think there's increasing energy and enthusiasm to change the formulations and use more child-friendly, but at the moment we're stuck with what we've got. And this is an example of a 6-year-old child, or 6-kilogram child, sorry, who's got MDR-TB. And this is the regimen that you want to use. Okay. So pyrazinamide, you say you're giving 35 milligrams per kilogram, they're 6 kilograms, so you want to deliver 210 milligrams. But the tablet only comes in a 500 milligrams, so you break it in half, you're giving 250, that's a bit too much, you're giving then probably 40, 45 milligrams per kilogram. So what do? Do you give a quarter? That's not going to be anywhere near enough. So that's a real challenge. Ethambutol, the same, you want to give 150 milligrams, the tablet only comes in 400, so you break it in half, it's 200 milligrams, you break in a quarter, it's 100 milligrams, so that's challenging. Moxifloxacin's a nightmare. It comes in a 400 milligram tablet, almost impossible to break even in half, let alone in quarters or eighths. And you want to deliver 60 milligrams. Ifeonamide, 120, that's not too bad to deliver, you can break that in half. But taururzolone, you say it's easy, it's half a capsule. But how are you going to deliver half a capsule? You're going to open the capsule, the powder's going to go everywhere, it's going to fall on the floor, and even worse for PASS, you can open this sachet of 4 grams, and you want to give just under a quarter of it. Linezolid, the tablets come in 600 milligrams, and you want to give 60 milligrams. Nightmare. And so you see, this is a PASS sachet which has 4 grams in it, 4,000 milligrams. You want to give 900 grams. How do you do that? So you take this mound of these slightly odd little granules and you divide it in half, and then you divide it in half again, and then you sort of take a little bit off. This tablet's the ethambutol, you break it in half, it cracks everywhere and crumbles, it goes on the floor, on your shirt. You want to give a quarter of that, it's very tricky. This is the capsule of taururzolone, you open it up, powder comes out, goes everywhere. I mean, I'm not being melodramatic, I'm just saying it's very difficult to dose this properly. Okay, I'm going to hand you back to Jen now, who's going to give some sort of practical tips on how to deliver some of these drugs.
Great. Thank you so much, James. I appreciate it. I think there were a couple of quick questions that I'll want to answer. Again, we're not ignoring your questions. I think we're going to answer most of them at the end. But one of our colleagues mentioned having a pharmacist prepare the medications, and these are our colleagues from the Philippines. And certainly engaging our colleagues in the pharmacy and pharmaceutical area is a huge help in this. And I know there are even some groups that have looked at compounding some of the second-line drugs to make a type of syrup that can be given to the child. So that's compounding, is when the drug is crushed or mixed with a liquid that can then be delivered to the child. So when you have a pharmacist, it's definitely good to work with them to prepare this, both because it gives the nurses and the parents headaches, but also because they tend to have scales that are a little more sensitive. The problem is in a lot of places there isn't a pharmacist to help. But it's definitely a great suggestion from our colleagues in the Philippines, so thank you. As Dr. Seddon was just pointing out, preparing the tablets and calculating the doses can certainly be complicated, but there's also an additional complication that comes in with once you've prepared your doses and you've calculated it, how do you get that drug into the child? And I think any of us who've worked with children or people who have children of their own know that even getting a little bit of a cherry flavored or nicely flavored syrup in a child on a daily basis can be challenging, let alone multiple drugs given to a child for a prolonged period of time. And so thinking through some strategies that we've tried, that colleagues of ours had tried, I put together a small list here. And really strategies for administration, they depend quite a bit on the age of the child. So with a 2-year-old child, some of your strategies might be very different than for an 11-year-old child. And we keep talking about children here, but I would also like to mention adolescents. You know, I think we tend to leave adolescents out of the equation when we talk about children, because they should be able to cough like adults, and we often don't have to calculate their doses like we do for smaller children, because most of them weigh enough to get adult dose range. However, there are 2 studies, one that was published and one that's forthcoming, that actually show adolescents with MDR-TB have worse outcomes when compared with adult and child cohorts. So just keep in mind adolescents need our help too. So the first real problem is the injectable. This is very painful. You often will run out of sites where you can give the injection, but our colleagues in Stellenbosch have really done some good work mixing this with lignocaine or lidocaine, and James can probably comment more on this, but it appears that doing so does not really affect the PK or the absorption of the medication, so this is a good strategy, and hot compresses. You know, pills can be difficult to swallow, so people may want to consider mixing the pills with more palatable and nutritious foods and beverages. And the Sentinel Project is actually doing a study on stability of the medications when mixed with different foods and beverages. We expect to have the results in June sometime. We mentioned nasogastric tube administration, and this may be necessary as a temporary measure. You know, I note a comment here saying it may be challenging considering that some of the medications get stuck in the NG tube, and sometimes it's difficult to know if the patient got all the medications, and that's very true. One of the things we're looking at in the study on food mixing is actually what happens to the medications when they're passed through an NG tube. So it'll be interesting to see that as well. Compounding, as I mentioned, is mixing this with some oral administration vehicles. It's like making your own syrup, and working with pharmacists can help with this. What's really important, I think, is to involve children and families in adherence measures and administration. Even very young children, if they can have some control over the process, tend to do better. So maybe asking them to take their pills on their own, or letting them know, you know, that they can be in charge of the time they take them, or other things like this. And also, I think providing some incentives for children is important. With younger children, it could be something as simple as a doll or a sticker or some crayons. With older children, you may want to consider as an adherence strategy, or as a strategy for administration, giving them airtime on a cell phone. They love that. We do recommend that any cutting or crushing of tablets should be done by health providers. It would be great if pharmacists can do this. And then again, I just mentioned if the tablets can't be crushed, cut, or compounded, one strategy I know that people have tried with clofazimine, which many of you know it comes in sort of a gel caplet, so you it's hard to cut, crush, and mix. But some people have tried giving the whole dose, but giving it every other day, so that the cumulative dose the child gets would be the same over time. I also see a colleague commented on using the pediatric dosing spoon for PASS. This is an intervention that was just approved by the European Medicine Association, and it's a pediatric dosing spoon made by a pharmaceutical company in Europe, and that spoon is now available. And then, you know, I noticed another question just to think about here is how do we select the sites for the injectable, especially in young infants and children with significant wasting. It's a very serious problem. Obviously, you want to give the injection in a site that has a significant mass, and so it can be very hard. We usually recommend the buttocks or the thighs, and even in children who are severely malnourished, we end up having to go this route. Intravenous administration of the injectables is certainly possible. I think the problem is that in many settings, children can't receive a long-term line like a PICC line or a Hickman line. So having an IV line in for longer periods of time puts them at risk for developing bloodstream infections. But certainly if the child can have a long-term or a midline placed, intravenous administration is very helpful. So these are some strategies. I think every hospital tries to have their own, and it becomes almost a daily struggle. I do want to point out, however, that children are very good about taking their medication. And one of the arguments we heard early in trying to treat children for MDR-TB was they'll never take their pills and they'll develop horrible side effects. And again, Professor Scaffa and Dr. Garcia-Prats will be discussing adverse events, but children tend to take and tolerate their medications well. So it's just something to think about. So I will turn back over then to Dr. Seddon. I know there are some questions coming up about certain medications, and I think Dr. Seddon will be able to address this as he talks about some studies that have been done in children, and certainly at the end of the presentation we'll make sure we get to everything. So back to you, James.
Thanks, Jen. I'll just quickly knock off a couple of the questions that have been asked. Someone's asked about prothionamide, and I haven't mentioned that specifically, but prothionamide and ethionamide are very, very similar drugs, and really they should be used interchangeably. So same dose, same indication, same side effect profile, and really you should use either one or the other, but not both. What do I think about ofloxacin is another question. Ofloxacin is a very good drug, should be part of the regimen, but it's probably better to use one of the higher generation fluoroquinolones if possible, such as levofloxacin or moxifloxacin, because they definitely have better efficacy. So those are a couple of answers there. And then finally a question about augmentin. Is it useful in the absence of imipenem or meropenem? And basically, if you give amoxicillin on its own, it can't get above the MIC of the bacteria as an antibiotic. But if you give the clavulanate with it, you can actually get some efficacy with amoxicillin. However, with the you can use augmentin with imipenem and meropenem, and then the clavulanic acid can also augment those as well. So we're going to move on. I am going to talk a bit about studies that have been done about MDR-TB treatment. And this is a systematic review and meta-analysis that was done a couple of years ago, which looked at all the studies which had been performed for MDR-TB in children. And there are two things to say about this. Excuse me. The first is that this includes 315 children. Only 315 children in the entire medical literature, which is sort of embarrassing and frustrating, but I think even now that in the last 2 years there's been quite a lot more than that. But the other thing to say about this is that treatment outcomes actually have been very good. Sort of 80%, over 80% have had positive treatment outcomes. In adults it's somewhere between 50 and 60. So children seem to do very well on treatment if they're diagnosed and put on treatment at the right time. Another concept I just want to introduce, and this is not really to advise, it's just to start people thinking about how we should be managing children with drug-resistant TB. Now, I apologise, that reference is not right. It's 2012 rather than 2021. It's not a journal from the future. And just to think that actually as the bacillary load in paediatric TB increases, at some point we go from saying they've got TB infection to saying they've got TB disease. But instead of it being just a binary thing where you've got either infection or disease, I think it's probably useful to start thinking of children as having, and I know it's a continuum obviously, but to think that children can have severe disease, which is the sort of TB meningitis, spinal TB, extensive parenchymal lung disease, big cavities, those kind of things. But there's also a large number of children, especially if you pick them up early through contact tracing, who really just have limited lymph node disease, either in the neck or hilar lymph node disease in the lungs, or just some streaky infiltrates in the lungs. And these children, it may not be necessary to treat them as severely and for as long as some of the adult studies have shown is necessary. Adults, there's a one-size-fits-all. All adults need 6 months of injections, 18 months total therapy minimum. And that's probably valid because most adults are diagnosed on the basis of sputum, so they have a significant bacillary load. Whereas a lot of children really don't have that higher bacillary load, and perhaps, and this is only a perhaps, we might be able to get away with giving children who have limited disease more limited regimens. And this is just to show a child with pulmonary disease, hilar lymphadenopathy. If he's given proper appropriate medications, that X-ray will return to normal fairly quickly. You'll kill the bacilli there, and he will have a log number fewer of bugs in his body than this child who has extensive disease throughout his body and in his spine. This is just to illustrate that point slightly. This is a study I was involved in Cape Town a few years ago. 150 children treated for MDR-TB, some of them confirmed, some of them not confirmed, but presumed. and young children, and about 20% HIV infected. And what you find from this is that the treatments are mainly with high-dose isoniazid, pyrazinamide, ethambutol, ethionamide. A proportion were given amikacin. Most had a fluoroquinolone. In this case, in response to that question about ofloxacin, they were given ofloxacin because other fluoroquinolones weren't available in South Africa. And the majority had taururzidone. A lot were given injections. They were given intramuscularly. And a significant pill burden for many children. This is an adolescent boy who's got TB and HIV. This is his daily pill burden. And what you find so interestingly, I think, here is that if you divide the children into the severe disease and into the non-severe disease, quite a few of the non-severe disease were treated as outpatients, and quite a few of the non-severe disease didn't need any injectables or weren't given any injectables. And as of these 104, all of them had favourable treatment outcomes, you can say they didn't need injectables. And for those that did get injectables, they were given shorter durations, and their total duration of therapy was shorter. Now, this is not a trial, and this is not kind of providing conclusive evidence, but it is hinting at the fact that actually, if you identify children early with MDR-TB, children who are maybe contacts, and you pick them up early and you treat them early, it may be that you can treat them for shorter durations and with less aggressive regimens. So this is just something to think about going forward to the future. I'm going to hand you back to Jennifer to continue the story.
Great, thank you so much, everyone. And then just to answer a couple of the other questions that have popped up, I think some of our colleagues have mentioned they have had good luck using peripheral venous lines in children, and that older children definitely prefer this. I think I would also prefer an IV line to the daily injection. Another colleague noted that in the dosing table that the doses depend on the drug that's commercially available in each country, and that's certainly true. When we designed that table, however, we used the dosages that are commonly available through the Global Drug Facility, since this is how most countries actually procure their drugs for the treatment of MDR-TB. So then going back to our patient, he was started on an empiric regimen based on the drug susceptibility pattern of his uncle, since he was most likely exposed in the home, and I mentioned the regimen there. The plan was to treat him for 24 months, given that he had a large extent of disease, and the injectable was given for 6 months. He also did have a gastric aspirate obtained the day that he was started on therapy, and it was sent for culture. So after a month and a half of empiric MDR-TB therapy, the gastric aspirate done at the time of initiation showed that he had resistance to isoniazid, rifampin, ethambutol, streptomycin, and then all of the injectables, so kanamycin, capreomycin, and amikacin. And although people don't like this terminology, this is the kind of patient who might be called pre-XDR-TB, so he has resistance to all the injectables. So thinking that the kanamycin was maybe not helping, and that capreomycin sometimes has activity in strains that document resistance, although this is very low likelihood. The only thing that was done to help our poor little 3-year-old was that his kanamycin was changed to Caprio, and the rest of his regimen was continued. And this was what we had to do because it was the best we had at the time. But if our patient was being treated today, what do you think some strategies are that might be best for him? And Evgenia has put these up. So would you start him on 2 injectables to overcome resistance? Would you just stop his injectable? Would you consider adding additional agents or begin plans for bone marrow transplantation? And it's great, everyone's responded that they would consider starting additional agents, and the ones that we mentioned here are linezolid, clofazimine, and or delaminid. This is actually leads us into an exciting part of the talk, and something we don't usually get to discuss in MDR until the last couple years, which is new drugs and new regimens. So in order to talk about this, I'll again turn it back over to Dr. Seddon.
Cheers, Jennifer. So we're going to think briefly for the last sort of 10-15 minutes about the future. And there are a few things that people are getting excited by. One is sort of retooling the existing drugs we've got and thinking about how we use them better. Then also optimizing the PK on the drugs we've got, so we're giving the right dosages to the right children. And then thinking about new drugs that are finally coming out. And also not just thinking about drugs in isolation, but thinking about new regimens. And then thinking about other drugs which might not just be given to kill the bacilli. So I'm going to go through all these relatively quickly, but it's really just to tell you these things are happening and they're out there, and watch this space. So people are getting excited about clofazimine. It's a drug which has been around for a long time to treat children and adults with leprosy. There's quite a lot of experience in leprosy for clofazimine, not much experience in TB, but it does seem to have good efficacy. It doesn't have good EBA, sort of early bactericidal activity, but it does have very strong sort of effects in other models. And it's been a cornerstone of a regimen that I'm going to come to in a minute. Furidazine is an old antipsychotic that was actually discontinued because of toxicity, but it does seem to have some in vitro efficacy against sort of drug bacteria, mycobacteria, and also it sort of seems to potentiate other TB drugs through efflux pumps. People are getting excited about the fluoroquinolones and how they might be used, and new fluoroquinolones coming out, new dosages of fluoroquinolones, and linezolid, which I'll talk about in a bit more. We talked briefly about the beta-lactams in that it's the clavulanic acid. Does mean that you can then get some kind of efficacy from both amoxicillin and also the meropenem imipenem. People are getting excited about cotrimoxazole, metronidazole, the tetracyclines and disulfiram. And people, again, these drugs may or may not come back in a new wave to treat TB. As I mentioned, linezolid, so there's been a huge amount. This is a big study in the New England Journal in adults which showed really good efficacy in patients who had really failed XDR-TB treatment and seemed to have good effect with the addition of linezolid. And then sort of creeping out, you're getting treatment cohorts described for children, a few more in children, and then a really comprehensive review which was done by Tony Garcia-Prats on linezolid's use in children, and a few in adults. So linezolid definitely is an exciting drug that people are using more and more. And I think it's fair to say it definitely does have efficacy and improves treatment regimens, but it does have significant toxicity. It causes sort of bone marrow suppression, peripheral neuropathy, and can be quite an unpleasant drug to use. So it's about trying to figure out what is the right dose to minimize toxicity, but also to kind of keep the efficacy going. So PK, and the reason why I mention PK is I think for children, if we have efficacy that's been proved for a drug in adults, we don't need to prove efficacy in children. But for children, they do have specific issues to do with toxicity and tolerability, to do with formulations, and we've talked about that already, and the pharmacokinetics. And these are slightly older studies, but they really just illustrate that as children get older, and basically these are the oldest children going down to the youngest children, they get a lower exposure to the drug for the same milligram per kilogram dosage. And you see it here on the levofloxacin, and the same on ethionamide. So these are the youngest children down here, and here are the older children. So you give a child the same milligram per kilogram dosage, and you tend to get less of a dose, less of a concentration in the blood. And so we need to do these studies in children to figure out what is the right dosage to give children in different age groups. And more work is being done on this, particularly in South Africa, and there is new data coming out, particularly on the fluoroquinolones, the other second-line drugs, and the injectables, which should be coming out in the next year or so. So new drugs. This is exciting. Having not had any new drugs for a long time, suddenly there is a bit of a pipeline. Lots of stuff in preclinical development. Lots of stuff beginning to come out the other end. However, quite a big hole in the phase 1 studies. And this is concerning. But what is exciting is there are new drugs coming through. In terms of where these drugs work, I'm not going to go into this in too much detail, this is quite a lot of information, but what you can see is these drugs work in lots of different places. So you've got all the drugs that work on the cell wall, so you're seeing some of these new drugs coming in here. Some that have multiple targets, such as delamidid, works on the cell wall, but also inside the cell. Something like bedaquiline actually works on ATPase, so it might work not only on the actively replicating, but also the dormant bacilli. You get drugs which work within the RNA, within the DNA itself. So lots of different sites for the drugs to develop, and lots of different mechanisms of resistance, so hopefully not too much cross-resistance. And these are the two big ones that we're excited by. There's bedaquiline, which was came out a couple of years ago, now being licensed in the USA, and delamidid, which is licensed now in European Medicine Agency. We've now got preliminary WHO guidance on how to use bedaquiline, and probably there'll be some WHO guidance coming out on delamidid later on this year. Now this is only in adults. We've got no pediatric data, we've got no real pediatric pharmacokinetic data, there's no pediatric formulations or toxicity, but these drugs are there, they're out there in adults, and hopefully the pediatric data will be coming soon. So this is an exciting place to be for new drugs for TB. Now, drugs shouldn't only be used on their own, and instead of thinking about just developing new drugs, people are thinking about developing new regimens. And there are a couple of ways of doing this. So either you try out lots of different types of regimen in mouse studies and then build them up to EBA studies, then build them up to clinical trials, and right from the word go, and you just drop regimens that don't seem to have efficacy. This is one way, which is a more modern way that people are developing regimens, which seems to be quite an exciting way to go. The other way is just really trying different regimens in sequential cohorts. So this is a study that was done in Bangladesh, which has informed a lot of new drugs now, where patients were sequentially treated, different cohorts were treated with 15-month regimens with different drugs, each kind of 6 months or so a new regimen was tried. And what surprisingly, this sort of study showed that this 9-month regimen actually had the greatest efficacy. So this is a successful outcome. You're saying this regimen 6 has a nearly 90% successful outcome, and that's a 9-month regimen, including a higher generation fluoroquinolone with gatifloxacin and clofazimine used all the way through. And this is exciting, and it's on the basis of this that a number of trials have subsequently been done. Again, this is in adults, but it does, if this is shown to be effective in adults, almost certainly we're going to see it percolate down into children. So I've just put this slide in. I'm not going to go into this in much detail, but I just want to sort of flag up the idea that I think in the next few years we're going to see more and more drugs that are given to TB patients, not to kill the bacilli, but to improve the host's ability to mount an immune response to the bacilli. And in TB, a lot of the problem is too much inflammation. This is sort of cavitatory disease. This is TB meningitis. We've got too much inflammation. Then there's a whole amount of TB which is not enough immune response. They're not stimulated enough, and this is disseminated TB and other things. And there's other elements that maybe other drugs might stabilize the immune system and give a balanced inflammation. This is the kind of Goldilocks hypothesis of inflammation. And effectively, I think we will see more and more of these drugs coming into trials and then coming into routine practice as time goes by to try and modify the way the immune system responds to TB. So this is another thing to watch out for. This is a very good review article which was published this year around World TB Day, which reviews this in some detail. There are a whole host of other things which can be considered sort of ancillary or supportive elements, which if we don't get these right, all these new drugs and new regimens are going to be a bit irrelevant. We need to support people in terms of taking their drugs. It's irrelevant having a great new regimen if someone's not actually taking them. So thinking about creative ways of delivering the medicines, thinking about rewards, incentives, using mobile phones, much more creativity. Thinking about formulations. Children do not like large, big tablets, so thinking about sprinkles or melts that just go under the tongue. If we could get an aerosol or a nebulizer for pulmonary TB, or ideally a depot injection that you have to give once a month, all of these might be amazing in the future. Addressing nutrition has to be a crucial part of TB treatment, otherwise you're not going to get anywhere, as is giving antiretroviral therapy if someone has HIV. The relationship with TB and worm infections is very complicated, but there's no doubt that helminths influence which type of T-cell helper cell response you get. And there's some conflicting data that some of the worm infections skew you towards being more susceptible, others are more protective, and also there's more work being done on protozoal infections. So I think watch this space on this one. And vitamin D also clearly has a strong relationship with TB, and thinking about maximizing vitamin D levels will almost certainly help that response. So I'll hand you back to finish up the case.
Great, so thank you, and I'm going to try to knock off a few of the questions because I recognize that we only have about 5 minutes left. So can people hear me? Hello? Sorry. So the first is what about the use of pyrazinamide in MDR-TB patients? I think most of us do keep pyrazinamide in the regimen no matter what the DST shows, with this idea it may have a sterilizing effect, but also that pyrazinamide resistance testing is not that great. In general, it's a well-tolerated drug, but if you have a patient who develops liver function abnormalities, you may want to consider taking it off. If you only have GeneXpert available to you in an abnormal chest x-ray, some people do consider treating with isoniazid, pyrazinamide, and ethambutol. It really depends on the age of the child and the setting in which you're diagnosing their TB. In younger children where they most likely got it from the household, if the household contact has resistance to all those other drugs, then I would use that. If it's an older child and you're not sure where they got infected, I don't think it would be wrong to give them isoniazid, pyrazinamide, and ethambutol in addition to the rest of the MDR-TB regimen. The rifampin dose that we recommend in MDR is the same at 10 milligrams per kilogram. There are multiple studies going on right now looking at higher doses, and we'll keep our eye on those. And then as a comment, one of our colleagues mentioned that of the new drugs that are in the pipeline, only 3 of them come from new classes. There's a question about the dose of lidocaine, and I'll defer that to Dr. Seddon when he comes back. But just to give you the good news that our patient was actually cured of his MDR and made a full recovery. He received 6 months total of the injectable and 24 months total of the drugs. He's finishing secondary school and living a full and happy life, and he's had no long-term effects from his MDR, except he plans to become a doctor and help other sick kids. And this is actually a picture of him in the middle there with some relatively important people, but to me, he's the most important. So in summary, we think you should suspect MDR if the child's unwell with a clinical TB contact or a known MDR source. Try to get microbiological specimens if you can, but certainly don't wait for those if you have a very sick child. Initiate treatment with at least 4 drugs likely to be effective, and be aware that new and repurposed drugs and new regimens will be available soon. So I'll turn over to Dr. Seddon here to answer the question about the lidocaine dosing, and then we'll go from there.
Yeah, no, in terms of lignocaine or lidocaine, I don't think there's any evidence to say what is the right dose. There's a study going on in Cape Town at the moment to try and see if giving lignocaine with an injectable affects the pharmacokinetic, or actually does it genuinely change the perception of pain. Now, the way the group there have given the lignocaine is with a sort of slightly different dose depending on how big the child is and how much of the injection you're giving. So it's not one amount of the local anesthetic for everyone, and there's a table which I'm sure when that article comes out later in the year there'll be a ratio for each of the different injections. Off the top of my head I can't remember what it is, but it's I think the best thing to do is give a little bit more for larger dosages, obviously, so you're covering yourself. Any other questions that we can think about? There's a question asking about how do we manage contacts of MDR-TB, and we haven't mentioned that at all today. We will address that in a subsequent lecture.
Actually will be addressed in the June lecture by Dr. Garcia-Prat and Professor Scoff. So stay tuned for that, and thank you everyone for the kind attention. We appreciate it. I see a couple more questions coming up. So how did we decide for 24 months total in our patient? We decided with a longer therapy in our patient because he was so sick and he had such severe disease. So that was the maximum that we went to. So, and then there's another question about, we mentioned it's helpful to know the child's BCG status. His BCG would not have put him at greater risk for having MDR-TB, but we know in young children if they've received BCG, it might be protective against meningitis and disseminated disease. So it's more of a question on being clean rather than anything that would put this child at risk. The best injectable, some people do say capreomycin, as it may have less ototoxicity, but there's never been a head-to-head study of any of the injectables looking at them in terms of their different toxicities. This was largely based on the experience of our group in Peru in the early days, and so I think any injectable will work. And, you know, ototoxicity is a severe problem that Dr. Scoff and Dr. Garcia-Prat will be talking about. The mention of clotrimazole or some of the other sildenafil, I think, James, I'll have to turf that to you. And then any long-term outcome studies on MDR-TB treatment, I'll also turf that to Dr. Seddon.
Okay, I think we should probably wind up. I'll just, in terms of the sildenafil and other adjuvants, I would probably refer you to that review article by Kaufman et al. In Lancet Respiratory Medicine, which goes into detail in some of the immune modulatory drugs, rather than me go into it now, because I don't think we've got time. And in terms of long-term studies, I don't think we've got them, I'm afraid. Anyway, I think we'll better wind up, and we'll hand back to our lovely host to say goodbye.
I'd like to sincerely thank you, our wonderful lecturers, for a very informative and interesting webinar. And I also thank you all the participants who joined us today. And as mentioned, you will be also able to view the recorded webinar and the slides on the MDR-TB Training Network website.